For the work and the journey that I'm sharing with you, the source of funding came from, for the discovery of our aging brain care program that I'll explain, came from the following grants from the NIH. And for the delivery part of the aging brain care came from a mixture of grant from CMS, from the Administration of Community Living, NIMH, and Ashkenazi Health Foundation. So I want to thank all the foundations and the NIH and that supported all the work that I'm sharing with you. So what I hope over the next 45 minutes or so is to cover the following objective of my talk. The first one, I'll discuss individual and family and societal burden related to Alzheimer's disease and other related dementia, and I'll focus how this burden affected my family personally. Then I'll try to review the discovery to delivery, almost 2-decade journey of the collaborative dementia care model that we developed over here in Indianapolis and have expanded it across the country and even overseas. And then I'll end with a little bit of introduction of Agile Science and its derivative as a science that help us implement evidence-based healthcare solution in general, but more specifically implementing our evidence-based collaborative dementia care model. So that's kind of the three objectives that I will cover over the next 45 minutes or so. So let me start with the dementia problem. Um, I'm sure all of you know about the dementia problem, but the dementia problem have affected my family. The picture that you see on this slide is my father, who I lost last May to dementia. But I am very honored that I was able, with support from my family and support from the science, to keep my father in his own home, in his own building, in his own community for the last 12 hours of his life. And we were able to do that even though he lived in a war, fall apart country from civil war in Syria. Despite that, because we had internet access and we have WhatsApp app, I was able to act as the care navigator who supported him and my mom in their journey coping with the cognitive, physical, behavioral, and psychological disability related to my father living with dementia and the stress that my mom had to deal with as the caregiver of my father. And we were able to do that because we were able to deliver the collaborative dementia care model to them through um, the internet, through WhatsApp. But my father, in our personal story with my father, is not unique to our family. Over here in the United States, there's at least 3 million Americans who are experiencing the cognitive, functional, behavioral, and psychological disability related to their underlying Alzheimer's disease and other related dementia. And I don't need to let you know that living with Alzheimer's disease and other related dementia lead to poor quality of life, not just for the person who live with the disease, but also for the unpaid or the informal caregiver, which most of the time is the spouse, sometimes are the daughter, and very rarely could be a friend. The people living with Alzheimer's disease and other related dementia and their family caregiver have a higher utilization of emergency room visit, most of the time inappropriately, and hospital visit, not just for the patient, but also for the caregiver. And the patient living with dementia spend more days compared to those who don't live with dementia in a nursing home facility. So they leave their community much earlier, sometime 2 to 3 years earlier. And if they are beneficiary from Medicare, their Medicare spending is 3 times more than the average Medicare beneficiary. And if they are in a relatively poor financial situation and they need Medicaid to support them on top of Medicare, their Medicaid spending is 19 times greater than the average Medicaid beneficiary. Most of that spending is due to living in a outside the community in a nursing home facility. When we faced this problem at Indiana University, we faced it as part of a scientific village. I'm just simply a one member of this scientific village. Um, I was mentored and trained by a pioneer in this field. I have highlighted my primary mentor, Dr. Chris Callahan, who became not just my mentor, but my friends, my boss, and my best man in my wedding. I also was supported with an amazing scientist and biostatistician, Dr. C.U. Hui, and an amazing leader, Dr. David Wilkes, who was the Vice Dean for Research at Indiana University. Now, all the work that I'm sharing with you, specifically the non-pharmacological interventions, the strategy that our coaches use to coach the caregiver and how to cope with the cognitive, physical, functional, behavioral, and psychological disability related to their loved one with dementia, all these tips, all these protocols were developed by an amazing person, Mary Ostrom, who we lost for a battle with pancreatic cancer almost 5 years ago. So thank you, Mary, for all your support. We have the next generation of people over here on our scientific village at Indiana University who are expanding the collaborative care model to make it more scalable, sustainable, and even move it to outside of population living with dementia to those who are critical illness survivors, delirium survivors, emergency surgery survivors, and even surgical trauma survivors.